Thank you for the invitation to speak on this distinguished panel. My name is Abra Shen, and I'm a fourth-year medical student at Harvard. I'll be speaking today about constructive criticism and unique challenges that women face when receiving feedback. Feedback is important. Formative feedback can result in measurable improvements in the learner's knowledge, skills, or behaviors. Many studies have shown that surgical trainees who receive feedback show improvements in technical performance, such as length of time and number of technical errors, compared with those who receive none. Unfortunately, women trainees receive less formative feedback than men. First, we'll discuss subjective feedback with a real-life example of two employees who are both struggling with working with customers. This was the feedback that Heidi received. Heidi seems to shrink when she's around others, and especially around clients. She needs to be more self-confident. This was the feedback that Jim received. Jim needs to develop his natural ability to work with people. Notice how the female employee lacks confidence, but the male employee simply needs to develop his natural ability. The same issue was given a positive spin when a man was struggling with it. This comparison shows a big issue with subjective feedback. It's based on one person's perspective. In contrast, evaluative feedback is designed to be objective and systematic using performance metrics that are observable and measurable. A study of 80,000 performance reviews found gender-based differences in subjective reviews, but no differences in objective numeric-based scores. Thus, objective feedback is less bias-prone. Unfortunately, women are 1.4 times more likely than men to receive subjective rather than objective feedback. Next, let's discuss attribution bias with another real example. Alice was given the feedback. Alice is a hard worker and spends long hours in the hospital. Bob was given. Bob has excellent technical skills and will be a great surgeon. Notice that Alice's feedback focuses on her effort, while Bob's focuses on his intrinsic skills. This is unfortunately common. Successes of men are often attributed to their internal abilities and skills, while successes of women are often attributed to external factors like hard work and just luck. The authors of an article that conducted research on women leadership said, as a woman rises into leadership, the mere fact that she is successful leads people to see her as succeeding against expectations, attributing her success to luck, the task being easy, or hard work rather than competence. Another issue is that, unfortunately, women themselves also attribute their own successes to luck. Gender-based personality traits also play a huge role in gender-biased feedback. These examples came from real evaluations of male and female emergency medicine residents. Wendy was told, Wendy argues a lot with the attending, is very confident in her diagnosis, and has a hard time entertaining other possibilities. Oliver was doing well. Oliver is sometimes argumentative, but he's trying to assert his confidence. Here, confidence for Wendy is a negative, whereas it's a positive trait for Oliver. This double standard is clear in our language. Surgery, as you all know, is historically a male-dominated field, and many traits associated with being a successful surgeon are masculine traits. For example, common words used to describe men: competent, confident, logical, practical. For women, compassionate, enthusiastic, energetic. And you can see here that there are far more negative attributes associated with women than with men. This issue has also come up not only in feedback, but also in recommendation letters, where research has shown that letter writers use stereotypically feminine words for female applicants, like being caring, rather than focusing on their achievements. Women have a harder time being evaluated as competent on traits that are traditionally considered masculine. Women face the predicament of having to be labeled as too soft, too tough, and never just right. We must be feminine but not too feminine, smart but not too smart, nice but not too nice. In over 200 performance reviews, of all mentions of being too aggressive, 76% occurred in women's reviews. When women act in ways that are consistent with gender stereotypes, they're often viewed as less competent. When women act in ways that are inconsistent with stereotypes, they're considered as unfeminine or too tough. And unfortunately, women leaders are perceived as competent but disliked. It's very rare to be both competent and liked. It's also important to recognize the impact of intersectionality. This graph is from a study that examined white and Black male and female leaders. This shows that after success, white men are rated higher on effectiveness than white women. The same trend is true for Black men and women, but note that the scores are lower for Black leaders. And after a failure, Black women are penalized far more than the other groups, who are rated about the same. Inconsistent feedback is another issue. These are real comments a resident received from 2 different attendings. Emma is progressing well, very thoughtful, reliable, appropriate confidence and autonomy. Another said, I would encourage Emma to be more assertive. She should let those working around her know that she is the team leader. Feedback should be clear and consistent, but unfortunately, women trainees disproportionately receive less consistent feedback. Men receive constant feedback focused on what they can improve on, whereas women receive inconsistent feedback generally focused on gender-based personality traits. Female residents were frequently praised for their performance as an autonomous leader by one attending, only to be criticized by another for being argumentative. Another important point is that women in surgery may receive more critical feedback to the point of harassment. There is not much literature describing this, so I reached out to surgical trainees and asked them to share their own experiences and examples of discrimination, abuse, and harassment as women in surgery. Here's what they said. In Grand Rounds and M&M Conference, every man is told, great save, don't be too hard on yourself, so well presented. Whereas every woman experiences a grueling interrogation to embarrass the presenter. Another said, being told you don't smile enough, being told you smile or laugh too much. Overly critical of women of color's operative technique, then remaining silent when the same technique is used by a white male. And finally, you're too pretty to be a surgeon. These are all examples of inappropriate, unhelpful, and discriminatory feedback. Now, I want to transition to what constitutes good feedback with concrete points for what can be done better. Good feedback, unlike all of the examples that I've given so far, should be specific, timely, actionable, appropriate for level, and given with the aim of being constructive. And when giving feedback, it's important to pick an appropriate setting. Do not use stereotypes. Be aware of conscious and unconscious biases. Use evaluative feedback with objective measurements to avoid subjective feedback. Your feedback should highlight abilities rather than effort and not be focused on just having good luck, and should actually provide concrete suggestions for ways to improve. Here's a list of my references. To conclude, I want to thank the women who shared their experiences with me, and thank you all for the opportunity to speak today.
Greetings. My name is Charity Glass, and I am a Chief Resident at Beth Israel Deaconess Medical Center in Boston, Massachusetts. I'm here to discuss receiving and assimilating feedback. Thank you so much for the opportunity to discuss this important topic in this venue. I will speak from the perspective of a trainee, but I hope some of these principles can be useful to those in other places in their careers, since surgery is a field of lifelong learning and improvement. I have no disclosures. Today I will discuss why feedback is important, some principles surrounding learning to receive and integrate feedback, separating the interpersonal differences from constructive feedback, and I will end with tips for seeking feedback. First, I'd like to convince you that feedback is a crucial component to our development as surgical trainees and surgeons. Studies have shown that intraoperative feedback can lead to a reduction in procedure time and improvement in economy of motion during cholecystectomy for surgical trainees. A review of 3 randomized controlled studies demonstrated that feedback was consistently found to be a powerful method for improving surgical performance in terms of operative metrics such as error scores and instrument movement metrics, as well as metrics specific to the procedure being undertaken. This is important to note because while none of these technical studies linked improvement in technical skill with associated improvement in clinical outcomes, one might suspect it would eventually lead to improvement in clinical outcomes, particularly in light of Berkmeyer et al.'s New England Journal of Medicine study, findings that technical skills rated by experts based on video footage correlate with surgical outcomes. This is important as the goal of all improvement is to provide better care for our patients. Excuse me, I have a little cold. Video-based coaching has been found to be instructive by surgeons of all levels. Individualized performance feedback to surgical residents has been shown to improve adherence to practice guidelines for floor-based work, such as prescribing practices for prevention of venothrombotic events. Hopefully, I've done my job convincing you of the value of feedback in improving your clinical practice. Let's turn to some of the reasons why accepting feedback can be challenging. We face several obstacles to being receptive to criticisms about our performance. The delivery is often harsh and inelegant. This sometimes goes hand in hand with our own self-doubt. Is this person just bad at giving feedback? Are they sexist, racist? Will this performance impact the way this person sees me forever? This is particularly challenging for women and minorities because of the added pressure of stereotype threat. Stereotype threat is a concept in social science that describes the anxiety individuals feel when they are at risk of conforming to a stereotype. Studies have shown students and academicians perform worse on tasks when reminded of stereotypes about groups to which they belong. Not to mention, there is not always dedicated, comfortable time for feedback. It often occurs during stressful situations where we are simultaneously trying to operate or manage a critically ill patient. Additionally, the learning culture at your institution might be more punitive than supportive. All of these obstacles come down to threats on our psyche. Harsh criticisms can disrupt our feelings of safety. It may cause you to feel this is not a safe place for making mistakes. It might make us question our self-worth. As a 2019 Harvard Business Review article by O'Brien claims, if our sense of self, egos, our very identities are tied up with our professional accomplishments, then professional failures or stumbling blocks can be more devastating as we are conflating our role or profession with our sense of person. I will discuss some steps for assimilating feedback. First, I think it's important to acknowledge that feedback is inevitable, so be prepared. Try to approach the situation with an open mind. Try to set aside your anger and defensiveness. Don't freeze or overreact. If you anticipate it, perhaps you'll be better able to take it in stride. When it happens, excuse me, calibrate, don't catastrophize. We are type A people who are used to performing at a high level. We are often our own harshest critics. So in the moment, feedback might create a lot of questions, from why you assigned yourself this case to more dramatic feelings like why you chose this profession. If you find yourself catastrophizing, take a step back. Remember, you worked hard to get to this point. You belong here. You have to take the feedback for what it is. Comments on an isolated task or series of tasks upon which you can improve. Next, apply the criticism to your role, not yourself. While the attack may feel personal, recall that needing to improve in an area is not a character flaw. In fact, it is the nature of this profession. I can often achieve this by reminding myself to focus on the goal, which is excellent patient care. I find that when you focus on the real reason we are all here, the patient, many things that appear difficult become easier. Accumulating different perspectives and more data can also be helpful. This bullet point refers to two separate but important concepts. If you receive some particularly jarring or inconsistent feedback, you can obtain confirmation of the critic's critique with more perspectives from other observers. When you're doing that case again, seek direct feedback about what you were critiqued on in the past. Additionally, this bullet serves as a reminder that you are learning new ways to do things and that these suggestions just give you more tools for your toolkit. If the feedback was particularly harsh or unsettling, reach out to your kitchen cabinet or whatever you call your unofficial personal advisory board and discuss it with them. My advisory board consists of fellow residents I trust, recent graduates, and attendings I know who are invested in my success. They can help you reality check the situation and limit your catastrophizing. Which leads me to the last point. Make a plan for improvement. Your kitchen cabinet can be your first sounding board, but involve your mentor, program director if you're a resident or fellow, advisor, if needed, to devise a plan for improvement. In the moment, if appropriate, you can ask follow-up questions to the person critiquing you to help guide your improvement. As surgery diversifies, you are likely to encounter individuals with whom you disagree. Separate those differences from technical feedback and feedback about patient care. Ask yourself, what can this person offer me? Keeping in mind that generally, everyone has something to offer. Sometimes it helps to pursue this thought exercise. How would I have reacted to this information if delivered appropriately by my favorite surgical mentor? Now I'll move to some tips for seeking feedback. If you're a resident, take advantage of the pre-op scrub sync chat. Some phrasing that has worked for me in the past is, I've done 25 lap choles and I think I'm pretty good at the dissection, and I'd like to work on operating with both hands instead of holding the camera in my left. Would it be possible for me to work work on that with you in this case. After the case, when finalizing post-op plans, you can say something like, I think I did X well, and I would like to work on A. Any other tips? Sometimes, something we all find frustrating is when you get the courage to seek out feedback, and all you get in response is something non-specific, generic, like, oh, you did fine. I found that asking for advice as opposed to feedback can be helpful when dealing with those reluctant to give feedback or those who just respond, everything is fine. You can ask them if they would have done something differently or how they approach a difficult aspect of the case. Specific questions tend to help elucidate more information from those who give generic feedback. In conclusion, sometimes you have to separate the feedback from the person giving it and their delivery style. Also remember to apply the criticism to your role, not yourself, by refocusing on the ultimate goal, excellent patient care and mastery of your craft. And last, asking for advice can be helpful in those reluctant to give feedback. Thank you so much for this opportunity.
Hello, everybody. For me, it's a pleasure to be here today, sharing with you during this talk in my experience in how to turn every interaction into a learning experience. My name is Paula Farad. I'm a professor of surgery at Virginia Commonwealth University. I direct a surgical and trauma ICU and also a fellowship. And I have no disclosures that pertain to this talk, except that I had plenty of opportunities to turn negative interactions in something positive. So I figure after all in my career path that when you get into a situation that might be difficult, everything is what you make of it, like this picture. The ocean can be beautiful and can be relaxing and can be also ferocious and dangerous and difficult, and you could be drowning. So at some point when you get these challenges in life, you can decide if they're going to become opportunities for you to grow and get what you want. But how do you do it? I truly believe that the reason why we don't do this as much and why these interactions that become unhealthy and at the end we don't get what we want or what we deserve is because we have bad stress. And what is the bad stress? You need a little bit of stress to perform well, but when the stress is too much, then you get paralyzed because you perceive danger and you have fear of failing. And what happens in your mind when you're stressed out? You get irritable, everything becomes an issue. You can get depressed, you can get anxiety, you get emotional paralysis, meaning when you're stressed out, sometimes you don't know which way to take. And you start getting forgetful, and then at some point you also can become isolated. And how do you stop it? How do you basically turn that stress into something that is going to help you perform and you don't get paralyzed or isolated? What has worked for me personally is looking at the big picture. Focus on your outcomes rather in what's happening immediately in front of your eyes, and think, you know, if you burn the house down, then how is that going to benefit or not benefit you in the long term in your career, or whatever, outside your career, at home, whatever it is. Know the perils of inadequate sleep. I don't have crucial conversations. In fact, I try not to have any important conversations if I'm post-call and I haven't slept for 24 hours or more. And avoid decision fatigue. There's a reason why, you know, you start, at least critical care doctor, I start rounding in the patients are sicker first rather than the other way around, because you have decision fatigue, and it's hard to take important decisions if you have been taking important decisions for an extended period of time. So allow yourself take a deep breath, allow yourself a break is one of the good ways to actually take good decisions. Focus on you. You know, you cannot control sometimes your environment or what other people are going to do, but you can control how you behave, and you can control how you interpret things, and you can control how, you know, how you take every challenge into an opportunity. Know your strengths, know your challenges, know what makes you happy. And for that, you need introspection and you need time. And I'm not talking about taking a year sabbatical, but time every day to think and to reflect on what's important for you. And what is not that important for you, try to triage it. You know, the most important person that you need to impress in life is yourself. And I think the moment that you understand that, you gain back control in your life instead of giving control and giving power to other people. At the very end, you just need to be able to look in a mirror and be proud of the things that you have done and the person that you become. What does all heroes have in common? They start with the status quo, meaning you start, if you think about all the movies that we have watched and the books that we have read, you start with the status quo, basically saying, you know, this is how my life is, and, you know, this is my routine. And then basically you get an invitation to do something else, like to start residency, or in a movie to go to an adventure. And that change can cause stress. During that change and that basically opportunity or challenge, you have, like, the hero has to go to war, then that person finds a mentor and a sponsor that is going to help them go through the particular situation so they can learn. And then they come the challenges, right? Our hero now is going to have to slay some dragons, and perhaps these dragons are too big, and perhaps you know, you realize that your like weapons are not good enough to kill these dragons, and then you have a crisis. And crises are hard and sometimes can be isolated, but it's not until you actually come out of that crisis that we can get the true hero becomes who she or he is supposed to be. And this is written in this book that I recommend everybody to read. It's called The Hero with 1,000 Faces. But if you think about your own life, or at least personally for me, there's not been any accomplishment that I had important in my life that hasn't come with hard work, disappointments, and crises that I have been able to overcome. And I think that when we change the way that we see failure into something depressing and frustrating and embarrassing, into something that you have to go through to be able to get to what you want, then you never lose. You either win or learn. Failing is the first attempt in learning. And I think that once we change our mindset to be ashamed of not doing well, than rather to learn and to become our better version of ourselves, then I think that change can help us turn every challenge into an opportunity. In order for us to get up, you have to fall a couple times, and that is just life. If you think about the babies, if a baby will fall and then never get up again and try again, then we'll have a bunch of people in wheelchairs, because, you know, I mean, what happened to your baby? Why doesn't he walk? Well, I guess walking wasn't for him. I think that it's not that nobody's born knowing exactly what to do and doing exactly what to do well. And we all have to understand that we all have to go through that process of transformation in order to become who we want to become, who we deserve, and to get what we deserve. And at the beginning, it's hard. You know, we all have a little bit of imposter syndrome, myself especially. So sometimes you think like, oh my God, you know, I don't know, the people are gonna one day wake up and figure out that that I'm not all that I'm supposed to be. You know, sometimes you just have to do it and do it again and do it again, and do it again, and every time do it better. Fake it until you make it. By repetition and by practice, we become good at what we're doing. And I think, and I don't only think about technique or clinical things in life. If you practice something, you become really good at it. So practice confidence, practice self-love, practice self-care, practice compassion, not only towards your patients, your partners, your family, which you probably already have a ton, but practice compassion towards yourself. When you fail, don't put yourself down. Talk to yourself, that voice that you had in your head, turn it into something that compassionate. Don't say things to yourself that you wouldn't say to a very good friend that you want to see succeed. Also, don't give your power away. This is a hard one for all of us. We're all busy. We all want to say yes to everything. We all want to please people, but at some point you have to understand that every time that you say yes to something, you're saying no to something else, and that no is usually towards yourself. Don't waste time, invest time. Believe in your ability to improve. There's a difference between a fixed mindset and a growth mindset. I personally work every day in trying a growth mindset, meaning do not let yourself be defeated. If you're not perfect at this now, you will at some point if you do it enough, if you practice enough. Every challenge is an opportunity to growth. And only you can control you. Like I said before, find your support system. It's really hard to go through this alone. Do not isolate yourself. There's a ton of us that had harder times and harder interactions with people, and we have been able to learn from it and come to the other side in a better light. So all of us are available to give you feedback and give you support and give you ideas, and you don't have to have a local mentor. You can have a mentor that is far away that can also help you by seeing things from a different focus. Getting what you want is simple, meaning you know what you want and you know where you're going, but it's not easy, and it doesn't supposed to be easy. I was reading these in social media at some point. It says that if you were successful, you needed to do all of these things. You needed to have disappointment, persistent, hard work, huge risk, and that's pretty much everything in life. Nothing about what we do is easy, but everything about it is worth it, and it requires taking time to understand what is it that you want, and so you can create a strategy and how to get it. This is my email and my Twitter handle. For me, it's a pleasure and an honor to be included in this panel of great women leaders, and my door is always open to anybody that want to talk. I think together we can make a difference, and together we can be powerful by numbers and stronger. Thank you for the opportunity to speak.
Good afternoon. It's my pleasure to talk about problem solving and communication strategies for difficult situations. I have no financial relationship or conflicts of interest in the material described in this presentation. Microaggressions are the everyday verbal, nonverbal, and environmental slights, snubs, or insults. Whether they're intentional or unintentional, they communicate hostile, derogatory, or negative messages to target persons based solely upon their marginalized group membership. So what I'd like to talk about is to teach us all to do better, to do the best until you know better, and then when you know better, to do better. Not only should we be people that don't communicate or use microaggressions, we also need to be able to react to those in our work environment who are using microaggressions to insult someone else. We become just by standing up and speaking out. We have to temper it by performing temperate actions. We have to be brave in order to speak up to make our environment better. So WAKE, Active Bystander Training, is something we've employed at Wake Forest Baptist Health. And we call it WAKE so we can remember exactly what we need to do. You need to work with who you are. Some of us, it's very easy to say, oh, I'm sure you didn't mean to insult her or him. Why don't you rephrase that or say you're sorry? Others, because of the hierarchy, may have to do it in a different way. You need to ask questions about what person said or did to see what their true intent was. And then who else can help you? Key people in the room, key people later on, those that can help you learn how to be a better active bystander. And then there are sometimes you need to employ distraction techniques because you can't solve the problem right away. And therefore you need to distract people so you can get out of the situation and then deal with it later. So the direct questions can be, what do you mean? Can you explain? Always assume the best. Dr. Meredith always tells us to assume virtual intent at Wake Forest Baptist Health. I know you really didn't mean that, but it came across this way. To call someone in, you say, can we talk about what just happened? Or you can call someone out. That's not cool. We have to do better. It's just a joke that we hear a lot, maybe in the operating room. I know you think it's just a joke, but I don't think it's that funny. And honesty. The truth is, that makes me feel uncomfortable. Thanks for understanding. And then you can be curious being a Wake Forest bystander. I wonder if we could provide her care if we did this. And then you need to acknowledge wrong. I see what's happening here. I feel bad about the interaction. And most people come to work to do a great job. So you can say you're a good person who cares about others, but what you said or did could be interpreted this way. So here's some examples. You're in the operating room doing a distal bypass on a patient and have the radiology technician page to come to the operating room with a C-arm to do a completion angiogram. The patient is under a spinal anesthetic. He enters the operating room making a lot of noise and complaining out loud that he is overworked and bothered by having to do this procedure. You introduce yourself as the surgeon and ask him to be quiet as the patient is awake under regional anesthetic, and he completely ignores you and continues to complain. You ask him again to be quiet, and he yells profanities at you. So this is the yeller. What do you do about this? This happened to me when I was a young faculty. And with this, I asked him to leave the room. I asked him to leave the room and not come back. We actually de-escalated the situation, got someone else in to help us with the C-arm and the x-ray, and later on talked to him and his supervisor so that this would not happen again. Again, the patient was the center of the attention here. Him yelling at me was totally inappropriate, and he actually ended up getting suspended and eventually fired. So our next steps are dealing, like I said, to talking it right then to de-escalate the situation, following up at the institution, and lessons learned about how to talk to people as they come into the room, perhaps saying, my patient's awake, so make sure you are quiet as you come into the room to take care of this patient. So I'm in charge. Case number 2, you book an emergency guillotine amputation in diabetic patient who has a necrotizing soft tissue infection of his foot. You go to the operating room and the anesthesia attendant decides to do a popliteal nerve block. You reluctantly agree but state that your operation will only take 20 minutes and the infection is quite severe. After 1 hour of trying to do the block, you ask him to stop and give a general anesthetic by mask so you can take off the infected foot. He walks over to you, puts his face within inches of yours, and tells you that he's in charge of the patient's anesthetic. Again, this happened to me too. I was a faculty member in Milwaukee, and I basically looked at him and said, in the patient's best interest, we need to put the patient to sleep now. We got that done. I did his amputation and left the room. He did call me minutes later and had a conversation. I basically told him I wasn't going to talk to him anymore about the situation. I did end up talking to my boss, who talked to his boss, and we found out this was not the first time that he did this, and therefore he was fired later. How do we prepare others to prevent these kind of behaviors? Again, we can teach everyone bystander training so that you are not the cause of the need of a bystander. And the last case, I wonder what he will be like. It's your first case as an attending surgeon at a new institution. You go to the room early and are sitting in one of the stools of the room waiting for the anesthesia team to bring in the patient. The 2 nurses for the room walk in and one says, this case is being done by one of our new attendings. I wonder what he will be like. So how do you respond? Basically, I introduced myself. This was at San Diego, and told him who I was. How would you coach others to prevent this from happening? I tell young faculty as well as students, always walk in the room, introduce yourself. I'm Dr. Freischlag. I'm the new vascular surgeon. I'm excited to be here. Can we go over the instruments? Can I meet all of you so this will be a successful operation? So for me, being much clear about my role, what I'm doing, and making sure that people understand that it's me who's the surgeon. I was the first woman surgeon ever hired there. So of course they wondered what he would be like. So you need to stand up, you need to speak out, you need to be brave. You need to know who you are and how you can deal with bystander training and how you can deal with micro and or macro aggressions. I think as we all speak out and we're more honest and true to each other, we too will have better situations and have less difficulty communicating in the hospital, in the operating room, anywhere. Thank you very much.
Hi, my name is Sharice Berry, and I'm an assistant professor of surgery at the New York University Grossman School of Medicine. I would first like to thank the college for the opportunity to participate on this panel and for the privilege of the virtual podium. My talk is entitled Challenges with Discrimination, a Call for Diversity. I have no disclosures. We will begin the talk with first describing discrimination within academic surgery and the effects of discrimination, implicit bias, and overt bias in the workplace. We'll then discuss racial disparities in health, and before ending the talk, we'll discuss why increasing diversity in surgery, achieving equity and social justice, and why allyship are all critically important. So this is the changing face of America. In looking at the racial breakdown of the country from 1950 to 2050, our country was 80% white in the 1950s. But by 2050, we will be a country that is 47% white. So is the changing face of America reflected in academic surgery? Well, to answer this question, you must look at the pipeline. Are we training a diverse workforce? So we evaluated the demographic trend of general surgery residency applicants, matriculates, and graduates from 2005 to 2018. Of the nearly 25,000 graduates of general surgery residency programs, only 10% were underrepresented minorities and 19% were Asian. So for underrepresented minorities, the proportion of applicants, matriculants, and graduates remained significantly low and unchanged, while the attrition was significantly higher when compared to whites or Asians. So why is the attrition rate higher for underrepresented minorities? Hughes and colleagues sought to determine the national prevalence and sources of discrimination based on race, ethnicity, in our general surgery residency programs. They also identified factors associated with discrimination, as well as how discrimination affected resident wellness. The overall prevalence of racial and ethnic discrimination was about 24%, but when stratified by race, Blacks had an overwhelmingly higher prevalence of discrimination at 70%, followed by Asians at 48% and Hispanics at 25%. Some of the sources of the discrimination included different standards of evaluation, denied opportunities, being mistaken for a non-physician, and slurs and hurtful comments. A multivariable logistic regression analysis in determining risk factors for discrimination, you were 20 times more likely to experience racial discrimination if you were Black and 6 times more likely if you were Asian. Residents who experienced discrimination reported higher rates of burnout, thoughts of attrition, and suicidal thoughts. So is the changing face of America reflected in academic surgery? Well, based on the data, we are not training a diverse workforce. Thus, with a homogeneous pipeline of trainees, we would expect to see that homogeneity reflected within the surgical faculty. So this is the position paper of the Society of Black Academic Surgeons Women in Surgery Committee. It's a committee that I chair, and we sought to report the prevalence of women surgeons among U.S. medical school faculty stratified by race, and to assess the number of NIH grants awarded to underrepresented minorities, particularly Black women surgeon scientists, over the past 2 decades. So when you look at the percentage of women among all faculty stratified by race, the disparities are striking. When you look at academic rank of all medical school faculty within the Department of Surgery stratified by race and gender, the disparities are striking. Out of nearly 3,500 professors of surgery, 51 are Asian women, 5 are Latina, and 10 are African American. So not only are there disparities in the diversity of medical school faculty, but the disparities extend through promoting female faculty of color. When you look at chairs of departments of surgery, the disparities are striking. So out of 337 chairs of surgery, 2 are Asian females, 2 are Latinas, and 0 are African American women. To date, there has never been a Black woman to ascend to the role of chair of surgery. So there are many types of diversity, seen and unseen. The question really is, why is diversity, equity, inclusion, and social justice so important? Well, the reason is because it affects patient outcomes. There was a study that showed that about half of medical students and residents actually believed that Black patients felt less pain when compared to whites. And other studies have shown that most healthcare providers appear to have implicit bias in terms of positive attitudes towards whites and negative attitudes towards people of color. COVID-19 has really unmasked long-standing racial and ethnic healthcare disparities and inequities. We actually found a 5-fold increase in the risk of a positive COVID-19 test among Black residents of New York City. And nationwide, the APM Research Lab found that COVID-19 death rate for Black, Indigenous, Pacific Islanders, and Latino Americans is 3 times the rate when compared to white Americans. Pregnancy-related deaths. Black and American Indian, Alaska Native women experienced higher deaths than all other racial and ethnic groups. And if you were Black and older than 30, your risk of death from pregnancy was 4 to 5 times that if you were white. So Black newborn babies in the US are more likely to survive childbirth if they are cared for by Black doctors, but 3 times more likely than white babies to die when cared for by white doctors. The mortality rate of Black newborns in the hospital decreased by between 39% and 58% when Black physicians were taking care of them. And by contrast, the mortality rate for white babies was largely unaffected by the doctor's race. So there's really a need and a call for action to increase diversity both at the level of the individual through education and allyship and at the level of the institution. It's really critical that we increase the underrepresented minority pipeline so that we are training a diverse workforce. Department of Surgery faculty and leadership should be a reflection of the diversity of people to whom they serve. Institutions must employ anti-racist, implicit bias, and cultural competency training. There should be a zero tolerance policy for all forms of racism, discrimination, and bias. Academic surgical leaders should sponsor and promote underrepresented minority faculty. And within departments of surgery, there needs to be transparency and accountability, which can be accomplished really through an equity committee. So Dr. Hannah Valentine from the NIH talks about the importance of an equity committee, really developing and implementing equity metrics for every division within the Department of Surgery ensures transparency and accountability. Some of these metrics would include, number 1, representation of underrepresented minorities within the faculty and at the leadership level. Number 2, discrimination reporting. Does the division have a system for collecting faculty reports of racism and a clear plan for when problems are reported? Number 3, racial, ethnic, gender diversity in speakers for grand rounds or invited lectureships. And finally, number 4, a metric to ensure faculty salary equity. Female surgeons earn 8% less annually than male surgeons. And on average, Black women in the United States are paid 38% less than white men and 21% less than white women. Allyship. So allyship is an active and consistent practice of using power and privilege to achieve equity and inclusion while holding ourselves accountable to the needs of marginalized people. As an ally, it's really important that you recognize your privilege and educate yourself. You have to first have a fundamental understanding of the history of racism in this country to be an effective ally. Check in with your underrepresented minority colleagues during times of social unrest and speak up when you witness implicit bias, microaggressions, or overt racism, and have a zero tolerance policy for racism and understand that silence is complicit. Hire, promote, sponsor, and support diversity and underrepresented minority faculty. There are several organizations and surgical societies, including the college, the AAST, EAST, the Association of Women Surgeons, and the American Surgical, who are beginning to really understand and prioritize the issue of diversity and inclusion, intersectionality, implicit bias, and microaggression by creating task force and committees and publishing white papers with recommendations and guidelines. Organizations such as the AWS, the AAST, and the American Surgical are also partnering with SBAS, the Latino Surgical Society, the Society of Asian Academic Surgeons, in creating fellowships and visiting professorships in an effort really to promote and give exposure to underrepresented minority female surgeons. Here's an example of true allyship. The current and former editors of JAMA Surgery using their privilege to create change by announcing a public call to action to all surgery journal editors for improving diversity in the editorial and peer review process. So far, half of the 215 surgery editors groups have provided support for this pledge. We have to remember that diversity at the highest levels of leadership at academic health centers really contributes to critical and innovative viewpoints and organizational level changes that ensures excellent patient care, groundbreaking research, and serves as a model for health professions education. I want to conclude my talk with a quote from a rising star in medicine, Tanya Fabo. She's an MD PhD candidate at Stanford. She graduated from Harvard University, where she earned her master's degree in medical anthropology and oncology from the University of Oxford. She's a Rhodes Scholar, a John Harvard Scholar. Our future is very bright. She says that our lived experiences inherently shape the way we think and the way we approach scientific problems. How can we expect to capture the full spectrum of scientific knowledge when there's only a portion of the population that's being represented in the sciences? Our voice matters, and if heard, science can be used to change the world. I want to thank the college again for the opportunity to be on this panel and to discuss this very important topic. Thank you.